Pal, Obstetrics and Gynecology, Apollo Hospital, Kolkata, deliver the keynote address on managing APLA in obstetrics.
Good morning. This is my first time I'm at Advances, and it's really a pleasure and honor to be here. I thank Dr. Jayakrishna and team for having me here. I have been given 30 minutes to speak on APLA in obstetrics, and I can assure you I won't take that long. I don't think we don't have enough to speak on only when we don't know much or we know everything about it. It's, I think, by the end of the talk for you to decide where we are in terms of our APLA. I bring you greetings from Kolkata, and APLA is antiphospholipid syndrome, or primary antiphospholipid syndrome it is called. And how is it defined? It is defined as the presence of antiphospholipid antibodies along with either thrombosis or adverse obstetric outcome. Now the thrombosis could be venous, it could be arterial, it could be in small vessels. And the adverse pregnancy outcome would be one of the three. Either it's 3 or more consecutive miscarriages before 10 weeks, one late miscarriage where there's a normal fetal morphology which we take as a miscarriage occurring after 10 weeks when we've already visualized the fetal heart, or one or more premature birth before 34 weeks with a normal fetal morphology due to either severe preeclampsia or severe placental insufficiency. So along with antiphospholipid antibodies in the blood, one would have to have either this obstetric history or a thrombosis. Now please remember, many of these women actually can have a thrombosis in the brain, and typically they have the thrombosis after they start a oral contraceptive pill for the first time. So it is essential to take a history of that kind of thrombosis as well. And what are antiphospholipid antibodies? At the present moment, it is a persisting presence of either lupus anticoagulant, anticardiolipin antibodies, or beta-2 glycoprotein 1 antibodies. And this has to be tested twice, theoretically, on separate occasion, at least 12 weeks apart. Now, all these three do not affect the obstetric outcomes similarly. Lupus anticoagulant appears to have the highest incidence of fetal loss, and beta-2 glycoprotein antibodies is somewhere in the middle, and anticardiolipin antibodies is possibly the better of the three. But all of them give rise to increased miscarriage or IVF, fetal growth restriction, or intrauterine fetal death. Now, is it important? If we take a normal population and say 100 women, in this room we test them for antiphospholipid antibodies, 2 of them will test positive. But among women who have SLE, around 30 to 40% of them test positive for antiphospholipid antibodies. Women who test positive for antiphospholipid antibodies, in their life, they have a 30% chance of developing a thrombosis. And women who develop severe early onset preeclampsia or FGR, about 30% of them test positive for antiphospholipid antibodies. About 15 to 20% of women who have RPL test positive for antiphospholipid antibodies. The live birth rate without treatment is only about 10%. And with treatment, we can take the live birth rate to 70 to 90%, not to 100%. A very important question is, how do we test for antiphospholipid antibodies? Now, if you look at the RCOG guideline from 2011, which has now been revised in 2021, it more or less says that there is a considerable inter-lab variation due to suboptimal sample collection, preparation, lack of standardization, and temporal fluctuation. So we need to be very careful when interpreting a negative result, and maybe we need to repeat it from a standardized lab. If we are doing a collection somewhere and then we are sending the sample, we need to make sure we centrifuge the sample before we send it. But lupus anticoagulant has to be tested indirectly. You do not have a direct testing. It is the least sensitive and the most specific. It can be tested with the APTT, with the kaolin clotting time, but the best way to test it is by the dilute Russell Viper venom test. Anticardiolipin antibodies and beta-2 glycoprotein 1 antibodies are tested by IgG and IgM. Now this is, we should look at Indian data at all times. And this is the data from KEM Hospital back in 2007. There's a famous hematologist who became the ICMR director, Dr. Kanjaksha Ghosh. It is, his team had published this, and they looked at prevalence of thrombophilia in 430 women with unexplained fetal loss. And they showed that anti-cardiolipin antibodies and anti-annexin antibodies were the severest in terms of fetal loss, and lupus anticoagulant and beta-2 glycoprotein antibodies were slightly better in terms of the fetal loss. However, in 2019, there's a meta-analysis which is published which shows that looking at all studies, they show that lupus anticoagulant seems to be the most dangerous, and followed by anti-cardiolipin antibodies. So with this bit of knowledge, we move on to how do we manage antiphospholipid antibodies. Now, when we manage women with primary antiphospholipid syndrome, we can divide them into two groups of women. We can divide them into women who've got a prior thrombosis and women who've not had a prior thrombosis. Now, women who've not had a prior thrombosis means either they have had a recurrent early miscarriage, or they had a late miscarriage, or they had a preterm delivery due to severe preeclampsia or severe placental insufficiency. Now, women who've had a prior thrombosis, they will need prophylaxis throughout the pregnancy. But prophylaxis with a usual dose of thromboprophylactic dose might not be enough. Depending on what trait they are carrying, depending on what kind of thrombosis they had, it might be important, it might be necessary to do the prophylaxis with higher doses of low molecular weight heparin. It may be 50% higher than the prophylactic dose, it could be 75% higher than the prophylactic dose, or it could be double that of the prophylactic dose, which is usually the therapeutic dose. And how long should we give it? We should give it from the time she is pregnant till 6 weeks after she delivers. Or instead of 6 weeks after she delivers, if she's going to be moved on to warfarin, then we can stop it sooner and move on to warfarin, because warfarin can be given safely when the woman is breastfeeding. What should we use? We usually use a low molecular weight heparin, because now the price of low molecular weight heparin has come down. But if she cannot afford to have a low molecular weight heparin, we can always use unfractionated heparin. And unfractionated heparin, we use it every 8 to 12 hours to maintain APTT at 1.5 times that of control. Now, antiphospholipid syndrome with a previous venous thrombosis or arterial thrombosis, it is good to involve a hematologist or a rheumatologist. But if she has had a recurrent venous thromboembolism, it is imperative that we discuss it or involve in her care a hematologist or a rheumatologist. Now, please remember that we use low molecular weight heparin because it has got several advantages over unfractionated heparin. The biggest problem with unfractionated heparin that it can cause heparin-induced thrombocytopenia. And heparin-induced thrombocytopenia is of two types. One is, it is called HIT type 1 or HIT type 2. HIT type 1 is essentially an idiosyncratic reaction which happens within the first week, whereas HIT type 2 happens essentially in a dose-dependent manner. So if we are putting somebody on unfractionated heparin, we need to check the platelet count after a week, and then at regular intervals, maybe every 2 weeks. Secondly, if you are putting somebody on heparin as a therapeutic agent, we need to go on looking at the APTT regularly. The third problem is the incidence. Suppose the patient is on heparin, at that point of time she requires an intervention. The risks of bleeding are higher with heparin than with low molecular weight heparin. And finally, when a patient receives heparin for 6 to 9 months or more longer than that, the risks of bone loss is more than that of low molecular weight heparin. It is because of all these reasons that we prefer to use low molecular weight heparin. Now, I just want to bring to you that what is the dosage of low molecular weight heparin in prophylaxis. Now, it looks very complicated, but sorry, is there can I use this as a pointer? No, pointer? Okay, thank you. So, essentially we use enoxaparin and very, very rarely dalteparin. I think most of us use enoxaparin. So enoxaparin, please remember, for prophylaxis, we use 40 milligram per day in women who are between 50 to 90 kilo. And between 90 to 130 kilos, we use 60. So what we need to remember is the prophylactic dose for enoxaparin for most women is 40, that is 50 to 90. If it is less than 50, we use 20. If it is 90 to 130, we use 60. If it's more than 130, consult a rheumatologist. And the dose equivalence of 40 to dalteparin is around 5,000 units. So that is how we calculate. 50 to 90 is 40, less than 50 is 20, 90 to 130 is 20. Anything beyond that, consult the rheumatologist. 40 milligrams of enoxaparin is equivalent to 5,000 units of dalteparin. But if we are talking of therapeutic dosage, the therapeutic dosage for non-pregnant population is 1.5 milligram per kg of body weight once daily. But about 10 years back, the British Society of Hematologists recommended that women in pregnancy, pregnant women require a higher dose, so they should be given 1 milligram per kg of body weight twice daily. About 5 years after they came out with their recommendation, they did an audit of what people were using, and they found still a lot of people were using 1.5 milligram per kg of body weight. And then they looked at what was the incidence of getting a thrombosis while on that dosage, and they found there was no difference. So the current guideline for pregnant women is they can get 1.5 milligram per kg of body weight once daily, or they can get 1 milligram per kg of body weight twice daily. And of course you need to move it to the, because it is available as 20, 40, 60, you need to move it to the, round it off to the nearest one. So that is how we look at that, that between 50 to 70 kilo, they should get 60 twice daily or 90 once daily. And 70 to 90, they should get 80 twice daily or 120 once daily. And if you can see, between 50 to 90, the prophylactic doses was 40. So it is important to involve a hematologist or a rheumatologist and refer to the chart whenever you are putting them on a therapeutic dose. And especially women had a prior thrombosis, we would possibly give them a dosage which is somewhere between a prophylactic dose and a therapeutic dose, and that is what we need to be deciding. Now what we do in a patient with antiphospholipid syndrome who's not had a prior thrombosis, which means that they've either had a recurrent consecutive 3 miscarriages early, or 1 late miscarriage, or 1 preterm delivery before the 34 weeks because of severe preeclampsia or severe growth restriction. Now we need to understand that there is a lack of control trials on these, and we actually make our recommendations based on very, very small studies which I'll show you in a moment, and a lot of data comes out from case series, and there is no large publication on this after the year 2014 or 2015. But we need to understand that these women are at a high risk of thrombosis, and experts recommend that they should require aspirin along with low molecular weight heparin or heparin. And why, I will come to that in a moment. But there is a lot of confusion about how much aspirin, how much low molecular weight heparin, and when should we be started and when should we stop it. Aspirin we should start once the urine pregnancy test is positive, but it can be started prenatally also while the patient is trying to get pregnant. Please remember that in antiphospholipid syndrome, the dosage of aspirin is 75 milligram per day. There's a lot of confusion about this. Now, there are 3 reasons why we use aspirin. One is for antiphospholipid syndrome, one is for prevention of preeclampsia based on history, and one is for prevention of preeclampsia based on the 12-week scan. If we use aspirin for prevention of preeclampsia based on the 12-week scan, only then we use 150 milligram. If we are using aspirin for prevention of preeclampsia based on history, we use between 75 to 100. But if you are using it for antiphospholipid syndrome, we are using 75. Why we are using 75? Because the studies which looked at aspirin use 75. So we do not know it is the right dose, but that is the evidence that we have. When should we start the low molecular weight heparin? The earlier Royal College guidelines said you should start it once you see the fetal heart, whereas the American guidelines said start it when the UPT was positive. And we saw that when we used to start it after the fetal heart was positive, some women some miscarriages would happen even before we could have started. So we've all gone back, and the RCOG new guideline says start it as soon as the urine pregnancy test is positive. And as I said, for most women between 50 to 90 kg, start it on enoxaparin 40 milligram per day or dalteparin 5,000 units per day. When should you stop aspirin? As Dr. Shobna said, actually you do not need to stop, but everybody stops between 34 and 36 weeks. When should you stop low molecular weight heparin? The studies do say that you should stop it at 36 weeks. But please remember that these women are at a higher risk of thrombosis, so there is no problem in continuing it, because anyway it is recommended that they should give it. If they don't have a prior risk of thrombosis, they should get it low molecular weight heparin post-delivery up to around 7 to 10 days. So again, I'm highlighting the dosage of prophylaxis. For 50 to 90, it is 40 milligram, less than 50, it is 20 milligram, above 90 to 130, it is 60 milligram. But this is what I'm talking about. If you look at where this comes from, now there are only 2 studies, total of 140 women, which looked at aspirin plus unfractionated heparin versus aspirin. And one of these studies came long back from Dr. Leslie Reagan's unit. And these 2 studies showed that there was a benefit in terms of your take-home baby rate if you used aspirin plus unfractionated heparin. There is one study which looked at low molecular weight heparin plus aspirin versus aspirin, very small numbers of 98 did not reach statistical significance. But because we know low molecular weight heparin is as effective as heparin in different studies, so now we have actually replaced the heparin with low molecular weight heparin, although not a single study has managed to show a benefit. Aspirin versus placebo, 3 studies of 135 women, and it didn't show any benefit. Should we use prednisolone? Should we use IV immunoglobulin? And I say about this when we are talking of recurrent miscarriage as well. Now there are 2 studies, very old studies. Prednisolone, at one point of time for antiphospholipid antibodies, women were given prednisolone. And prednisolone plus aspirin, there are 2 studies of around 300 women, and it showed that if you give added prednisolone, there was a significant increase in prematurity and more GDM compared to if you gave the patient aspirin or heparin. And that is why I keep saying, if in many conferences somebody would come up and say, I use intralipid, I use intravenous immunoglobulin, those are all anecdotal. Till they have been tried in research settings and comes in clinical practice, please don't use them. Let your friends use new drugs because we do not know the side effects yet. Similarly, IV immunoglobulin plus unfractionated heparin and aspirin versus unfractionated heparin plus aspirin, it shows increased risk of pregnancy loss and preterm birth if you used IV immunoglobulin. So there is no role of using IV immunoglobulin or prednisolone in clinical practice in antiphospholipid syndrome. So in antiphospholipid syndrome and recurrent pregnancy loss, aspirin and heparin are still recommended. Aspirin has started as soon as the pregnancy test is positive. Low molecular weight heparin started as soon as the pregnancy test is positive. What do you do about labor and delivery? You deliver them at term. If they're on prophylactic anticoagulant dose, we need to adjust it and stop the antithrombotics. If tell the patient that don't take any injections if you start bleeding or you have contractions. And if we are planning an elective cesarean or induction, we give the last injection 12 hours prior to the elective cesarean or the induction. If the patient is on therapeutic anticoagulant dose, then we stop the low molecular weight heparin 24 hours prior to elective cesarean or induction of labor. Now, obviously, if she is on therapeutic doses, she is at a high risk of getting a thrombosis. So in that case, we start them on IV unfractionated heparin, which we stop 2 to 4 hours prior to anticipated delivery. And we do a continuous electronic fetal monitoring in labor. Postnatally, we resume anticoagulation about 4 to 6 hours after vaginal delivery and 8 to 12 hours after a cesarean. In women with a prior thrombosis, we need to continue the prophylaxis for 6 weeks. In women without prior thrombosis, the UK guideline is essentially to give it for 10 days. Warfarin is safe during lactation, and we should avoid estrogen-containing oral contraceptive pills. And we need to tell these women that they've got a 30% risk of thrombosis in their lifetime, and they need to be careful about that, especially when they get immobile, bedbound for any reason, or if they have got a major surgery, they need to tell their physicians that. Once antiphospholipid syndrome is diagnosed, there is no need to test in future pregnancy, just treat. About 10 years back, a friend of mine from Mumbai called me back and said, I had this lady who was antiphospholipid positive, had a good outcome last time. This time I tested pregnant. I tested her again. She is negative. What should I do? I said, if you do an investigation, you do not know how to interpret, then you deal with it. That is why do not test it. If you tested positive once, treat her in the next pregnancy. This slide is just to highlight that there is no role of using aspirin or heparin or low molecular weight heparin or aspirin plus heparin in idiopathic recurrent miscarriage. There is enough data to suggest that it is no better than placebo. Having said that, when the history is suggestive of antiphospholipid antibodies and the tests are negative, are you going to treat or not? Now, there's one school of thought which talk of a seronegative antiphospholipid syndrome, but most people don't believe in it. And they define a seronegative antiphospholipid syndrome as somebody who's got a history suggestive of APLA but has not tested positive, taking into account the lack of standardization and sensitivity of the test. I do not know what is the right answer, but I can tell you what I do in these situations. I counsel women regarding the sensitivity of the test for antiphospholipid antibodies. I tell them that if we give her unnecessarily antithrombotics, what are the risks to her? I explain to her the treatment is empirical, and I explain to her the potential benefits of treatment if actually she is APLA positive and she has tested negative, and if she agrees, which she usually does, I take her consent and then I start her on that. Now, it's great. Antiphospholipid antibody syndrome is usually very rewarding. You treat them and they go home with a live baby. They don't even get into major problems. But typically patients who are APLA have had a previous thrombosis. Sometimes you will give them low molecular weight heparin and aspirin, and in spite of that, they will going to have an intrauterine fetal death, or they're going to have a severe placental insufficiency. What next? Very, very difficult situation. We consult the rheumatologist and the hematologist, and we increase low molecular weight heparin dosage. From 40, we increase it to 60. We add HCQS, and usually what we do is, if she, in spite of the treatment, if she gets into a miscarriage, then we usually increase the low molecular weight heparin. If she gets into problems in the second half of pregnancy, we tend to add HCQS. We have also sometimes increased the dose of heparin. But the point is that we do not know what it is. Now, there is also something called a catastrophic primary antiphospholipid syndrome. Fortunately, it doesn't happen in pregnancy. This is where the patient gets a series of thrombosis and recurrent thrombosis. And this happens in non-pregnant stage. An adverse outcome with antiphospholipid syndrome, adverse obstetric outcome, in spite of giving them low molecular weight heparin in the therapeutic dosage and aspirin, is more common in women who've had a previous catastrophic antiphospholipid syndrome. So to end my talk, antiphospholipid syndrome is the presence of antiphospholipid antibodies with thrombosis or adverse pregnancy outcome. Aspirin and heparin remain the treatment of choice and should be started as soon as UPT is positive. There is no role of antithrombotics in unexplained recurrent miscarriage, and the history suggestive of APLA with negative tests presents a clinical dilemma. And we can do a thrombophilia screen in unexplained second trimester miscarriages, but that's a different issue. I will end my talk. I would think it is not inappropriate to ask for your support and blessings. I'm contesting for the post of FOXI presidents. I have led the RCOG in India for 3 years, and before that East Zone for 3 years. I have led the Indian Association of Gynae Endoscopy and Bengal Society. I have served FOXI in many roles, including the journal and the ICOG, and as a committee chair and a vice president, and as a representative to an international organization. And the time has come to try for leading FOXI, and the elections should happen in August and the nominations in May. I seek your blessings. I'm happy to answer any questions.
Thank you so much, sir.